If you are listening to this right now, we know exactly where you are mentally.
Oh, absolutely. You are staring down the barrel of the plastic surgery in-service exam?
Or maybe you're finalizing your prep for the written boards.
Scrubbing into a 10-hour free flap?
Yeah. Or you're just driving home after a brutal night on call, trying to maximize every single minute of study time you have left.
Yeah, it's the grind.
It is. And the goal of this deep dive is to get you dialed in. We are not going to waste your mental bandwidth on esoteric one-in-a-million zebras.
No time for that.
Right. We are here to master the core patterns, the surgical anatomy, the exact algorithms for complication management.
And those specific non-negotiable numbers you are strictly required to know.
To pass the exams, sure. But more importantly, to operate safely when the drape goes up and you are the one holding the scalpel.
That is the exact mindset we need to maintain here. I mean, the transition from a junior resident to a chief and eventually to an attending is entirely about decision-making under stress.
100%.
Passing your boards and achieving true clinical excellence, they both rely on answering one fundamental question when things start going sideways.
What is the next step?
Exactly. What is the next step? It is never about having some vague theoretical understanding of a physiological concept.
No, the boards don't care about vague.
They care about the precise algorithmic progression of care. If you see this specific clinical presentation, you execute this specific action, boom.
So think of this deep dive as a high-yield walkthrough from your senior mentors. We're going to break down the most critical, highly testable scenarios you're going to face.
Let's get into it.
But just a quick reminder before we hit the heavy physiology. Everything we discuss here is built for your education, your board prep, and your pattern recognition.
Right. It is absolutely not a substitute for your specific institutional protocols.
Or the direct real-time guidance of your attending surgeons. You treat the patient in front of you based on the clinical reality of your hospital.
But for the exam, the board examiners have established a very specific set of rules.
And expected answers.
And we are going to learn those rules cold.
Okay, let's start with the absolute bedrock of plastic surgery. Wound healing and graft survival.
We spend our entire careers manipulating tissues.
So the cellular cascade of wound healing needs to be completely automatic for you. You have to know the progression.
Hemostasis, inflammation, proliferation, and remodeling.
That sequence dictates everything we do in the operating room.
It dictates every outcome, successful or failed. You have to be able to visualize what is happening at the cellular level the exact moment you make an incision.
So hemostasis.
Hemostasis is immediate. It happens in minutes to hours. The vasculature constricts.
Platelets aggregate.
Right, a fibrin clot forms, and those platelets degranulate. They release critical growth factors into the wound bed.
Like PDGF and TGF-beta.
Exactly. And that sets the stage for the second phase, the inflammation phase.
Which dominates the next few hours to days.
Neutrophils are the first responders here. They clear out bacteria and debris.
But the real directors, the heavy hitters of wound healing, are the macrophages.
The macrophages arrive slightly later. Their transition from a pro-inflammatory state to a pro-reparative state is the actual trigger for the next phase.
And this is highly testable, right? Because if a wound gets stuck in the inflammatory phase...
Which happens due to a retained foreign body or heavy bacterial colonization or sheer stress.
It becomes a chronic wound. It just stalls out.
It stalls. But if you can clear the inflammation, you move into the proliferation phase.
That spans days to weeks. This is the heavy lifting phase.
Fibroblasts migrate in. They start laying down an absolute abundance of type 3 collagen.
You get angiogenesis.
That's where you see that raw, beefy red granulation tissue. And the epithelial cells start migrating across the surface from the wound edges.
Beautiful. And finally, you enter the remodeling phase.
Which lasts for weeks to months, sometimes up to a full year.
That disorganized type 3 collagen we just talked about.
It gets systematically replaced.
By the much stronger type 1 collagen.
Exactly. The collagen fibers undergo cross-linking, and that drastically increases the tensile strength of the scar.
But here is the most highly testable concept. The trap that examiners absolutely love to set.
The ultimate tensile strength of that mature scar.
It never, ever returns to 100% of uninjured skin.
It maxes out at roughly 80%. That's the number. 80%.
Even a perfectly healed, meticulously closed, uninfected surgical incision
will only ever reach a fraction of its original mechanical integrity. That is a permanent structural deficit you have to account for.
Especially when you're planning closures over joints or areas of high tension.
Always. Now, If we take those exact same metabolic demands and apply them to a skin graft, we have to understand a very specific timeline of survival.
Because when you lay a piece of skin onto a recipient bed, you have severed its entire blood supply.
It's completely ischemic. It has to survive a highly precarious sequence to achieve take. The first phase is plasmatic imbibition.
And that occurs from hour 0 to 48.
During this critical window, there is zero active blood flow. The graft is surviving purely by the passive diffusion of nutrients and oxygen from the recipient bed.
It's essentially acting like a biological sponge.
Just soaking up the plasma exudate, the graft actually gains weight. It becomes edematous during this phase.
Then right around the 48 to 72 hour mark, we hit inosculation.
This is where the microscopic capillary buds from the underside of the graft and the surface of the recipient bed physically align.
They kiss.
They kiss, they connect, and they establish a provisional connection. You get this sluggish initial flow of cells.
And then from day 3 to 5 and beyond, the definitive phase takes over, neovascularization.
Entirely new blood vessels sprout from the recipient bed and grow directly into the dermis of the graft,
Permanently integrating it.
So the sequence is plasmatic imbibition, inosculation, neovascularization. If any mechanical force interrupts that sequence,
The graft dies.
the graft dies.
That physiological tightrope leads us perfectly into another massive area of foundational knowledge, local anesthetics.
And the absolute nightmare scenario of local anesthetic systemic toxicity. Or last.
Last is one of those clinical emergencies where a delay of even a few seconds in recognition can literally lead to a fatal outcome.
As a plastic surgeon, you are constantly utilizing large volumes of local anesthetics. Wide local excisions, massive tumescent infiltration for liposuction, complex facial lacerations.
You must know your maximum weight-based doses with absolute certainty. Let's run them. Lidocaine without epinephrine.
The maximum safe dose is 4.5 milligrams per kilogram, with a hard systemic ceiling of 300 milligrams.
And when you add epinephrine,
The vasoconstriction drastically slows the systemic absorption of the lidocaine into the bloodstream. That allows you to increase the maximum dose to 7 milligrams per kilogram.
with a hard ceiling of 500 milligrams, 7 and 500.
Right, and you have to know the numbers for bupivacaine just as well. We use it constantly for longer-lasting regional blocks.
For bupivacaine, the toxicity threshold is much, much lower,
It is 2.5 milligrams per kilogram without epinephrine.
and 3 milligrams per kilogram with epinephrine.
Because bupivacaine is highly lipophilic, it binds aggressively to cardiac sodium channels. Its cardiac toxicity profile is significantly more dangerous than lidocaine.
The arrhythmias it causes are notoriously refractory to standard resuscitation.
So you have to be vigilant. Picture a scenario in your clinic. You are doing an awake liposuction case. You're utilizing a large volume of tumescent fluid.
The patient is chatting with you.
And suddenly they interrupt to ask why they have a strange metallic taste in their mouth.
Red flag.
Massive red flag. They tell you their lips and tongue feel numb. They complain of ringing in their ears.
That is the classic prodrome. Metallic taste, circumoral numbness, tinnitus.
These are the early neurological warning signs of LAST. The local anesthetic is crossing the blood-brain barrier. It's initially blocking the inhibitory pathways in the cerebral cortex.
And because the inhibitory pathways are blocked first, the excitatory pathways run unchecked.
Exactly. If you fail to recognize this immediately, the patient will rapidly progress from muscle twitching and agitation straight into generalized tonic-clonic seizures.
And right after the seizures,
Severe central nervous system depression, respiratory arrest, and cardiovascular collapse.
the window to intervene is incredibly narrow. When that patient mentions the metallic taste, your mind needs to immediately jump to the salvage protocol.
You do not wait to see if it resolves. You stop the injection immediately.
You call for the crash cart. You secure the airway to ensure adequate ventilation.
Because hypoxia and acidosis will drastically worsen the toxicity and lower the seizure threshold.
If they start seizing, you immediately treat the seizures with benzodiazepines.
To suppress that cortical excitability. But the definitive life-saving reversal agent that you must command the room to prepare is intravenous lipid emulsion therapy.
The lipid sink.
The lipid emulsion acts as a pharmacological sink. Local anesthetics are highly lipophilic, so infusing a massive lipid load into the bloodstream essentially pulls the anesthetic molecules out of the cardiac and cerebral tissues,
It traps them in the plasma lipid compartment.
allowing the heart to restart. You run the lipid emulsion concurrently with a modified ACLS protocol. You have to know where the lipid emulsion is kept in your surgery center or hospital.
Absolutely. Okay, moving from acute pharmacological optimization to chronic physiological optimization,
Yeah.
we have to discuss the single greatest modifiable risk factor in reconstructive surgery.
Nicotine.
We demand that our patients cease smoking or vaping prior to complex procedures. But you need to understand the exact mechanisms of why nicotine is so catastrophic.
Particularly in microvascular free tissue transfer.
It's not just a general recommendation for lung health. Nicotine is an incredibly potent peripheral vasoconstrictor.
It stimulates the release of catecholamines, which literally clamp down on the delicate microvasculature of our flaps and grafts.
Furthermore, nicotine dramatically increases platelet adhesiveness. It elevates levels of thromboxane A2.
Creating a highly thrombogenic environment within the microcirculation. When you are performing a microvascular anastomosis on vessels that are 1 or 2 millimeters in diameter,
The last thing you can afford is a hypercoagulable state, combined with intense vasoconstriction.
the risk of flap thrombosis, marginal necrosis, and catastrophic wound dehiscence just skyrocket.
And we have to be clear with our patients. Vaping is not a safe alternative.
Even nicotine replacement therapies, patches, gums, they deliver enough systemic nicotine to severely compromise a delicate reconstructive effort.
When a wound fails to heal or an incision completely breaks down, it is rarely a mystery.
If you objectively analyze the situation, wound failure almost universally falls into one of 4 major physiological buckets,
Let's run through them. The first is infection.
which prolongs the inflammatory phase and destroys that provisional matrix we talked about.
The second is ischemia.
Whether from arterial insufficiency, venous congestion, or systemic factors like smoking.
The third is the physical separation of tissue layers.
Most commonly caused by an undrained hematoma or seroma that creates a dead space barrier,
And the fourth is excessive tension.
which mechanically shears the healing tissue and compromises the local capillary perfusion. If you meticulously control for infection, ensure robust perfusion, obliterate dead space, and strictly offload the area.
The human body's intrinsic healing capacity is remarkable.
It really is.
Before we transition into specific surgical techniques, we have to touch on the statistical concepts that frequently appear on the boards and in our journal clips.
You don't need to be an epidemiologist, but you must be able to instantly differentiate the utility of these metrics.
Let's look at relative risk versus odds ratio. They measure different things based on the architecture of the study.
Relative risk, or RR, is the cornerstone of prospective cohort studies and randomized controlled trials.
It calculates the actual probability of an outcome occurring in an exposed group compared directly to an unexposed group.
It's highly intuitive. Odds ratio, or OR, is entirely different. That's the hallmark metric used in retrospective case control studies.
Instead of tracking patients forward in time, you start with the disease state and look backward.
Right, you calculate the odds of prior exposure in the disease group versus a healthy control group. The critical caveat is that the odds ratio only provides a reliable approximation of the relative risk when the disease or outcome in question is relatively rare.
And the other calculation you need to know cold is the number needed to treat, or NNT.
The formula is beautifully simple. 1 divided by the absolute risk reduction.
The conceptual takeaway is that you are looking for the smallest number possible.
If a new prophylactic antibiotic protocol has an NNT of 2, it means you only have to treat 2 patients to prevent 1 surgical site infection.
Yeah.
That is a massively powerful intervention.
But if the NNT is 500...
The clinical utility is highly questionable.
Exactly. Okay, section 2. Let's move into the foundational techniques of plastic surgery, focusing on scar biology, local tissue rearrangement, and the principles of microsurgery.
Let's start by contrasting the 2 primary pathologies of abnormal scarring: hypertrophic scars versus keloids.
The clinical distinction here is paramount because the treatment algorithms differ significantly. Let's talk hypertrophic.
A hypertrophic scar represents a robust, overly enthusiastic healing response. The scar becomes raised, intensely erythematous, and often pruritic.
But the defining characteristic
Is that a hypertrophic scar strictly maintains the original boundaries of the surgical incision or injury. It does not invade adjacent normal tissue.
and they often naturally regress and soften over the course of a year or two.
A keloid is a completely different pathophysiological entity.
It's biologically aggressive.
It demonstrates an aggressive, almost tumor-like overproduction of collagen that overtly extends beyond the original wound margins. It invades the surrounding healthy dermis.
They have a notoriously high recurrence rate.
And they are disproportionately common on the anterior chest, the deltoid region, and the earlobes.
Because keloids are so biologically aggressive, simple surgical excision is universally condemned as a standalone treatment. If you just cut out a keloid and close the skin, the sheer surgical trauma will almost certainly trigger the formation of an even larger keloid.
So what's the treatment ladder? It begins conservatively for both types. We rely heavily on silicone sheeting or silicone gel.
Which works by increasing stratum corneum hydration and downregulating fibroblast activity.
We also utilize continuous pressure therapy. If conservative measures fail, the gold standard is intralesional corticosteroid injections.
Typically triamcinolone alone.
Right. It directly inhibits collagen synthesis and promotes collagen degradation.
Only after these modalities are exhausted, or in combination with them, do we consider surgical excision paired with immediate adjuvant therapy.
Like localized radiation.
Managing scar tension and redirecting vectors is the core of our local flap designs. And no local flap is more thoroughly tested or universally applied than the Z-plasty.
We utilize the Z-plasty to lengthen a contracted restrictive scar across a joint, or to strategically redirect a scar so that it falls seamlessly into the relaxed skin tension lines.
You must understand the geometry to predict the tissue mechanics. Let's talk about the classic, standard Z-plasty.
Designed with limbs of equal length and angle set precisely at 60 degrees.
That 60-degree angle is the magic number for the boards.
If you execute a textbook 60-degree Z-plasty, the theoretical length gain along the axis of the original scar is approximately 75%.
75%. You are essentially borrowing lateral tissue laxity and redistributing it longitudinally.
But you have to respect the vascular geometry.
Because if you try to cheat and maximize your length gain by utilizing narrower angles, say 30 or 40 degrees.
The tips of those transposed flaps become incredibly ischemic. You severely compromise the microvascular perfusion to the flap tip, and you risk devastating tip necrosis.
Which defeats the entire purpose of the reconstruction. Stick to the 60-degree, 75% length gain rule.
Let's pivot to skin grafting decisions.
Okay, you have a significant defect. How are you actively choosing between a split-thickness skin graft, an STSG, and a full-thickness skin graft, an FTSG?
The choice hinges entirely on the quality of the recipient bed and the cosmetic requirements of the site. Let's look at split thickness.
An STSG harvests the entire epidermis and only a variable portion of the underlying dermis.
Because it is physically thinner, the metabolic demand is significantly lower.
Therefore, an STSG has a remarkably high take rate, even on marginal, poorly vascularized recipient beds like irradiated tissue or chronic granulating wounds.
And the donor site is left with a portion of the dermis intact, allowing it to heal spontaneously via reepithelialization from the dermal appendages.
However, there are major functional and aesthetic trade-offs with split-thickness grafts.
An STSG undergoes severe secondary contraction as it heals. That can lead to joint contractures. Aesthetically, it often heals with a shiny, hyperpigmented appearance that provides a poor match for the surrounding skin.
Conversely, a full-thickness skin graft harvests the epidermis and the entire unadulterated thickness of the dermis.
Because it contains the complete dermal matrix, an FTSG provides a vastly superior color, texture, and thickness match.
Crucially, it undergoes minimal secondary contraction,
making it the absolute gold standard for reconstructing cosmetically sensitive, highly mobile areas.
like the lower eyelids, the nasal tip, or the fingers.
But the metabolic cost is high. An FTSG requires a pristine, robustly vascularized recipient bed to survive that initial plasmatic imbibition phase.
Furthermore, because you have harvested the entire dermis, the donor site cannot heal on its own.
It must be surgically closed, primarily.
Regardless of which graft you select, the most common, entirely preventable cause of graft failure remains constant.
It is the accumulation of a hematoma or a seroma beneath the graft.
We discussed the absolute necessity of inosculation, the physical linking of capillary networks.
Right. If a collection of blood or fluid accumulates between the recipient bed and the graft, it acts as an impenetrable physical barrier.
The capillaries cannot bridge the gap.
The graft is deprived of oxygen, and it undergoes complete ischemic necrosis. Meticulous hemostasis prior to graft placement is not just a suggestion.
It is a biological imperative. If you see a hematoma forming under a fresh graft in the early postoperative period, you must immediately evacuate it.
Let's escalate the complexity and talk about flap monitoring in the microsurgical setting.
You're doing your postoperative rounds, and you walk into the room to check on a free flap. Let's say an anterolateral 5 flap used for a lower extremity reconstruction.
You need to instantly differentiate between the two major modes of vascular failure.
What does venous congestion look like at the bedside?
Venous congestion is, statistically, the most frequent cause of early microvascular compromise.
The arterial inflow is intact, aggressively pumping blood into the flap.
But the venous outflow is obstructed, perhaps due to a kinked pedicle, a tight closure, or a thrombus at the venous anastomosis.
Clinically, what do you see?
The flap will appear deeply cyanotic, taking on a dark purple or blue hue. It will become massively engorged and edematous, demonstrating increased tissue turgor.
And the capillary recell?
It will actually be overly brisk, often less than 1 second, because the microvasculature is distended with trapped blood.
If you perform a pinprick test with an 18-gauge needle,
You will get immediate, dark, brisk bleeding. Paradoxically, if you listen with a handheld Doppler, the arterial signal might sound completely normal.
which can provide a false sense of security. The blood is getting in, it just has nowhere to go. The tissue is essentially drowning in its own deoxygenated blood.
Now, contrast that dramatic presentation with arterial insufficiency.
The arterial anastomosis, thrombosis. The flap is starved of inflow.
The tissue will appear starkly pale and feel cold to the touch. The capillary refill will be incredibly sluggish or entirely absent.
When you perform the pinprick test,
There is absolutely no bleeding. The tissue is completely dry, and your Doppler assessment will reveal an absent or severely diminished arterial signal.
when you identify either of these presentations, your action plan must be immediate and decisive.
At the bedside, you immediately remove all compressive dressings. You inspect the wound for any tight sutures that might be strangulating the pedicle and release them.
You optimize the patient's physical positioning to ensure there is no mechanical compression on the vascular axis.
You ensure the patient is normotensive and adequately hydrated. But here is the absolute non-negotiable rule of microsurgery.
If a free flap demonstrates signs of vascular compromise in the early postoperative period, you do not observe it.
You do not wait to see if it improves.
You do not rely on topical vasodilators or medicinal leeches for an acute anastomotic failure.
You declare an emergency, mobilize the team, and return the patient to the operating room for immediate surgical exploration.
Time is tissue. Early operative re-exploration is the only definitive way to salvage a failing anastomosis. Do not hesitate. Take them back.
Okay, let's transition into the realm of skin oncology and vascular anomalies, Section 3.
This is an area heavily dependent on algorithmic precision and pattern recognition. Let's run through the surgical excision margins for malignant melanoma.
These margins are dictated entirely by the Breslow depth, the microscopic measurement of tumor thickness from the granular layer of the epidermis down to the deepest point of invasion.
Okay, rapid fire. If the dermatopathologist reads the biopsy as melanoma in situ, meaning it is confined entirely to the epidermis, what is the required surgical margin?
For a confirmed melanoma in situ, the standard-wide local excision margin is 0.5 centimeters of clinically normal-appearing skin.
And if the Breslow depth is invasive, but measures less than 1 millimeter?
For tumors less than 1 millimeter thick, the surgical margin increases to exactly 1 centimeter.
Moving deeper, if the Breslow depth is between 1 millimeter and 2 millimeters?
For tumors between 1 and 2 millimeters, the accepted margin is 1 to 2 centimeters. Though clinically, most surgeons will aim for the full 2-centimeter margin, if anatomically feasible, to ensure definitive clearance.
And for any melanoma with a Breslow depth strictly greater than 2 millimeters?
The required margin is a definitive 2 centimeters. You do not need to take margins larger than 2 centimeters.
Because massive historical trials have proven that taking 3 to 5 centimeter margins provides no additional survival benefit.
It only vastly increases the reconstructive morbidity.
Drill those numbers into your head. In situ is 0.5. Less than 1 is 1, 1 to 2 is 1 to 2, greater than 2 is 2.
Now, aside from wide local excision, we have to evaluate the regional lymph node basin.
What are the specific indications to perform a sentinel lymph node biopsy?
The decision to perform an SLNB is primarily driven by the tumor's Breslow depth. The risk of microscopic nodal metastasis correlates directly with tumor thickness.
Generally, any melanoma with a Breslow depth of 0.8 millimeters or greater is an indication for an SLNB.
However, for thin melanomas, those less than 0.8 millimeters, you must look at the high-risk histopathologic features.
If the pathology report describes the presence of ulceration
Or a high mitotic rate.
or lymphovascular invasion,
You strongly consider an SLNB even for a very thin lesion.
let's shift our focus to the non-melanoma skin cancers. They represent the vast majority of our oncologic caseload.
Basal cell carcinoma, or BCC, is by far the most common human malignancy.
It is relentlessly locally destructive, often presenting as a pearly papule with arborizing cholangiochasias. But its metastatic potential is exceedingly rare.
Squamous cell carcinoma, or SCC, is the second most common, but it carries a significantly higher risk of metastasis, particularly to regional lymph nodes.
SCC is also the classic pathology that develops within areas of chronic inflammation, long-standing burn scars, chronic venous stasis ulcers, hidradenitis suppurativa tracts.
When an SCC arises in these chronic wounds, it is termed a marginal ulcer, and it behaves much more aggressively than a typical sun exposure SCC.
When managing these tumors, especially on the face, we frequently utilize Mohs micrographic surgery.
Mohs surgery is a specialized technique that allows for the immediate, complete microscopic examination of the entire surgical margin, while simultaneously minimizing the excision of healthy adjacent tissue.
We rely on Mohs primarily for tumors located in high-risk anatomic areas, specifically the H-zone of the face.
The H-zone encompasses the central face, the periorbital regions, the nose, the upper and lower lips, and the ears.
Areas where preserving every millimeter of normal tissue is critical for aesthetic and functional reconstruction, but where incomplete tumor clearance would be devastating.
We also utilize Mohs for tumors with aggressive histologic subtypes like morphiform BCC, or for recurrent tumors that have previously failed standard excision, and for tumors in heavily immunosuppressed patients.
Beyond BCC and SCC, there are two specific high-risk cutaneous malignancies that you must be able to identify and manage.
The first is Merkel cell carcinoma.
This is a highly aggressive neuroendocrine tumor of the skin, frequently associated with the Merkel cell polyomavirus.
It often presents clinically as a rapidly expanding, painless, violaceous, or plum-colored intracutaneous nodule. It has a high propensity for early lymphatic spread and requires aggressive multimodal therapy.
The second is dermatofibrosarcoma protuberans, DFSP.
DFSP is a distinct, locally aggressive soft tissue sarcoma. It often presents as an indurated keloid-like plaque on the trunk or proximal extremities.
The critical surgical feature of DFSP is its microscopic growth pattern.
It extends outward with long, asymmetrical, microscopic tentacle-like projections that infiltrate far beyond the visible borders of the central tumor.
Because of this insidious growth pattern, a standard narrow excision will almost universally result in recurrence.
DFSP requires extremely wide local excision, often 3 centimeters or more, including the underlying fascia. Alternatively, and increasingly preferred, Mohs micrographic surgery allows for the precise tracking and clearance of those microscopic tentacles while sparing normal tissue.
Let's wrap up this section by shifting gears to the pediatric clinic, focusing on vascular anomalies.
A highly anxious parent brings in their infant distressed by a prominent red vascular lesion on the child's face.
Your ability to instantly differentiate between an infantile hemangioma and a congenital vascular malformation dictates the entire trajectory of care. What is the fundamental clinical distinction?
The distinction relies almost entirely on an accurate clinical history regarding the timing of appearance and the pattern of growth.
A vascular malformation is a structural error in embryogenesis. Therefore, it is always present at birth, even if it is initially subtle.
Crucially, a malformation grows commensurately with the child and will never spontaneously involute.
An infantile hemangioma, conversely, is a benign vascular tumor.
It is classically absent or barely noticeable at birth. It typically becomes apparent a few weeks after delivery, and it immediately enters a rapid, alarming proliferative phase characterized by dramatic growth.
However, this is eventually followed by a prolonged involution phase, during which the hemangioma slowly shrinks, softens, and fades over several years.
The history of appearance after birth, followed by rapid growth, is the hallmark of a hemangioma.
Present on day 1, grows with the patient, never fades. Vascular malformation.
Appears at 3 weeks, grows rapidly, then eventually begins to regress. Infantile hemangioma.
We are moving right along into Section 4, burn physiology and resuscitation. Managing a major burn requires a deep understanding of systemic pathophysiology, massive fluid shifts, and airway management.
Let's start at the bedside with the clinical assessment of burn depth. How do we visually and tactilely differentiate a superficial, partial thickness burn, a deep, partial thickness burn, and a full thickness burn?
Let's take them one by one. Superficial partial thickness.
It damages the epidermis and the uppermost papillary layer of the dermis. Clinically, it presents with prominent blistering.
When the blisters rupture, the underlying wound bed is intensely pink, moist, and exquisitely painful to air exposure. because the nerve endings are exposed and irritated.
The capillary refill is incredibly brisk. These burns generally heal spontaneously within a couple of weeks with minimal scarring.
Now, a deep partial thickness burn extends deeper into the reticular dermis. The appearance changes significantly.
It looks pale, mottled, or waxy white, and it is relatively dry.
Paradoxically, it is less painful to pinprick than a superficial burn because the deeper dermal nerve endings have been thermally destroyed.
The capillary refill is sluggish or absent. These burns have a very high propensity for severe hypertrophic scarring and often require excision and skin grafting for optimal functional outcomes.
And finally, a full-thickness burn, a third-degree burn.
Represents the complete thermal destruction of the entire epidermis and dermis, leaving no epithelial appendages for spontaneous regeneration.
The tissue feels thick, leathery, and completely inelastic.
It is totally insensate to any pain or pressure, and there is zero capillary refill because the entire dermal microvascular network has been coagulated.
These burns will never heal on their own. They mandate definitive surgical excision and vascularized coverage or grafting.
When dealing with major burns, the systemic inflammatory response triggers a massive systemic capillary leak.
The patient rapidly loses intravascular volume into the interstitial space. To prevent profound hypovolemic shock, we must execute aggressive fluid resuscitation.
Traditionally guided by the Parkland formula for adults.
Let's run the exact calculation.
The Parkland formula estimates the total volume of crystalloid fluid required for the first 24 hours of resuscitation. The equation is 4 milliliters multiplied by the patient's body weight in kilograms multiplied by the percentage of total body surface area, or TBSA, that is burned.
We specifically use lactated Ringer's solution to mitigate the risk of hyperchloremic metabolic acidosis that occurs with massive volumes of normal saline.
Once you calculate that massive total volume, the administration timing is the most critical factor.
The physiological capillary leak is most intense in the immediate hours following the injury. Therefore, you must administer exactly 50% of that calculated total volume within the first 8 hours.
But the classic board trap and the most common clinical error is the starting point of that 8-hour clock.
The clock begins at the exact time of the thermal injury, not the time the patient rolled through the doors of your emergency department.
If a patient is injured in a fire and transportation takes 4 hours, you only have 4 hours remaining to infuse that entire first half of the fluid volume.
The remaining 50% of the volume is then administered evenly over the subsequent 16 hours.
And remember, when calculating the TBSA using the rule of nines, you only include partial thickness and full thickness burns. You strictly exclude superficial first-degree erythema.
Beyond fluid management, you must be prepared for acute burn emergencies, specifically the need for surgical decompression. You must clearly understand the indications for an escharotomy versus a fasciotomy.
An escharotomy is an incision made strictly through the rigid, burned eschar down to the subcutaneous fat. It is indicated for deep circumferential burns.
Because a full-thickness burn eschar is completely non-compliant. As the underlying tissues become massively edematous during fluid resuscitation, the pressure builds relentlessly.
On an extremity, this creates a tourniquet effect, leading to distal ischemia. You perform an escharotomy when you observe pallor, profound paresthesia, or a loss of Doppler pulses distal to the burn.
On the torso, a circumferential chest burn acts like a rigid breastplate. It physically restricts thoracic expansion and causes severe ventilatory compromise.
A chest escharotomy releases that restriction, allowing the patient to breathe.
A fasciotomy, in contrast, requires incising deeply through the muscular fascia to open the actual anatomical compartments.
We perform fasciotomies to treat true compartment syndrome, which is most frequently encountered in high-voltage electrical injuries,
where there is massive, hidden necrosis and edema deep within the muscle bellies beneath unburned skin.
The final critical emergency in the burn bay is inhalation injury.
If your patient was rescued from an enclosed space fire, presents with severe facial burns, singed nasal vibrissae, or carbonaceous sputum soot in the airway, you must assume impending airway disaster.
The intense heat and chemical irritants cause massive supraglottic edema that can obliterate the airway within minutes.
You must have a remarkably low threshold for early prophylactic endotracheal intubation.
And in enclosed space fires, you are not just treating thermal injury to the airway, you are treating profound systemic chemical asphyxiation. You must immediately suspect carbon monoxide poisoning.
Carbon monoxide binds to hemoglobin with an affinity exponentially greater than oxygen. It creates carboxyhemoglobin and causes severe tissue hypoxia.
Crucially, a standard hospital pulse oximeter cannot differentiate carboxyhemoglobin from oxyhemoglobin.
Meaning the patient will display a falsely reassuring oxygen saturation of 100% while actively suffocating at the cellular level.
The immediate treatment is the application of 100% oxygen via a non-rebreather mask to competitively displace the carbon monoxide.
You must also suspect cyanide toxicity, generated by the combustion of synthetic plastics and upholstery.
Cyanide poisons the mitochondrial electron transport chain. It forces the body into anaerobic metabolism and presents as a profound, unexplained lactic acidosis.
Moving right along, Section 5, we are diving into craniomaxillofacial trauma and congenital anomalies.
Let's begin with the precise anatomy and clinical evaluation of the facial nerve, cranial nerve 7.
The facial nerve exits the stylomastoid foramen, enters the parotid gland, and arborizes into 5 major terminal motor branches. Let's review them from superior to inferior.
Temporal, zygomatic, buccal, marginal mandibular, and cervical.
When a patient presents with a deep facial laceration, you must systematically test the motor function of every single branch before you do anything else. How do we perform that physical exam?
It must be methodical. To evaluate the temporal branch, which innervates the frontalis muscle, you instruct the patient to forcefully raise their eyebrows and check for symmetrical forehead wrinkling.
For the zygomatic branch, innervating the orbicularis oculi, you ask them to close their eyes as tightly as possible, and you physically attempt to pry the eyelids open to assess muscle strength.
To test the buccal branch, which supplies the zygomaticus major and the upper orbicularis oris, you ask the patient to smile broadly or puff out their cheeks against resistance.
For the marginomandibular branch, controlling the depressor anguli oris, you ask them to strongly depress their lower lip and show their bottom teeth.
Finally, for the cervical branch, you instruct them to aggressively flex their neck or bare their teeth to activate the platysma muscle.
And there is a fundamental, non-negotiable rule when managing any deep laceration crossing the cheek.
If the laceration trajectory crosses a line drawn from the tragus of the ear to the mid-upper lip, you must maintain a high index of suspicion for an injury to the parotid duct, also known as Stenson's duct.
You must actively explore the wound for salivary pooling or cannulate the duct intraorally to confirm its integrity. But the most critical sequence regarding facial lacerations is this.
You must complete and document your entire motor nerve exam prior to injecting any local anesthetic.
If you inject lidocaine first and then find a unilateral smile asymmetry, you have no way of knowing whether the trauma transected the buccal branch or if you simply caused an iatrogenic nerve block with your anesthetic.
Let's shift our focus to the structural bony pillars of the face and the classic patterns of mid-face trauma. The Lefort classification system.
It describes predictable fracture lines through the maxilla and surrounding bones, essentially defining how the midface separates from the cranial base.
A Lefort 1 fracture is a transverse fracture, horizontally crossing the maxilla, running just above the apices of the teeth and separating the maxillary alveolus from the pterygoid plates.
This results in a mobile, floating, hard palate.
A Lefort 2 fracture is pyramidal in shape. The fracture line extends superiorly from the maxilla, running through the medial orbital walls and across the delicate nasal bones, essentially disconnecting the central midface.
A Lefort 3 fracture represents complete craniofacial disjunction. The entire facial skeleton separates from the cranium.
With fracture lines running transversely across the nasofrontal suture through both orbits and fracturing the zygomatic arches.
When reconstructing these fractures, the goal is always to reestablish the vertical and horizontal structural buttresses of the face.
Now, if we move down to the mandible, the paradigm shifts slightly. Mandible fractures are incredibly common, but the surgical approach is dictated by one overriding priority.
If a patient sustains a parasymphyseal or subcondylar mandible fracture, what is the single most important functional objective of our operative aware?
The absolute paramount priority in mandible fracture management is the precise restoration of the patient's pre-injury dental occlusion.
The anatomical alignment of the bone itself is entirely secondary to how the upper and lower teeth interdigitate.
If you place heavy titanium plates and achieve what looks like a perfect bony reduction on a CT scan, but the patient's bite is off by even a millimeter, the surgery is a failure.
Malocclusion leads to debilitating chronic pain, temporomandibular joint dysfunction, and an inability to masticate.
We achieve perfect occlusion first, often by placing the patient into maxillomandibular fixation, wiring the jaws shut, and only then do we plate the fractured bone segments.
Let's talk about the absolute most terrifying scenarios in CMF trauma, the vision-threatening emergencies.
You are the plastic surgeon on call. A patient arrives in the trauma bay after sustaining a severe blunt force injury to the eye, perhaps a strike from a baseball or a fist.
They are in agonizing pain. On exam, their globe is physically bulging outward, proptosis.
Their visual acuity is rapidly declining, the eye is rock hard to palpation, and they have an afferent pupillary defect.
What is the immediate diagnosis and what is your exact course of action?
The diagnosis is a retrobulbar hematoma. The blunt trauma has ruptured an artery deep within the enclosed, rigid, bony cone of the orbit.
As the hemorrhage expands, it has nowhere to go.
The intraorbital pressure spikes dramatically, creating a localized compartment syndrome. This crushing pressure severely compromises the central retinal artery and the delicate vascular supply to the optic nerve.
If this pressure is not relieved, irreversible ischemic blindness will occur within roughly 90 to 120 minutes.
This is a true drop-everything surgical emergency.
Yep.
You absolutely do not delay treatment to obtain a CT scan.
The definitive treatment is an emergent bedside lateral canthotomy and inferior cantholysis.
You crush the lateral canthus, incise it, and deliberately cut the inferior crus of the lateral canthal tendon to allow the globe to physically displace anteriorly,
Instantly decompressing the orbit.
You execute this procedure immediately, and then you call ophthalmology.
The moment you recognize the compartment syndrome, you cut the tendon. Save the vision. Worry about the eyelid reconstruction later.
Another incredibly common orbital injury is the orbital blowout fracture, typically involving the thin bone of the orbital floor. How does this present clinically?
An orbital floor blowout fracture frequently presents with diplopia. But the most concerning hallmark sign of an entrapped inferior rectus muscle within that fracture line is a severe restriction of upgaze.
You ask the patient to look up, and the injured eye physically cannot elevate.
This muscle entrapment can also trigger a powerful oculocardiac reflex, causing profound bradycardia and nausea when the patient attempts to move the eye.
You will also look for anophthalmos, where the globe sinks backward into the newly expanded orbital volume.
And hypoesthesia in the distribution of the infraorbital nerve, the V2 branch of the trigeminal, causing dense numbness over the ipsilateral cheek and upper lip.
Before we transition away from the face, we must briefly touch on the fundamental principles of cleft lip and palate repair.
The timing of these interventions is a delicate orchestration of anatomical growth and functional development. What is the standard timeline for surgical correction?
The general algorithmic framework dictates that the cleft lip repair is performed in early infancy, typically between 3 and 6 months of age, depending on the infant's weight and the specific protocols of the cleft center.
Repairing the lip early helps restore the sphincter function of the orbicularis oris and normalizes the aesthetic appearance of the midface.
The repair of the cleft palate, however, is intentionally delayed, typically occurring later in the first year of life, often around 9 to 12 months.
This specific timing represents a crucial compromise. You must close the palatal defect early enough to allow the infant to develop normal speech articulation and prevent permanent vilopharyngeal insufficiency.
However, performing extensive mucoperiosteal dissection on the palate too early can severely scar the growth centers of the maxilla, leading to profound midface hypoplasia as the child grows.
We balance the demand for perfect speech against the requirement for facial growth. Let's shift our focus to section 6, hand and upper extremity.
Hand surgery is heavily tested because the anatomy is unforgivingly precise. A millimeter makes the difference between perfect function and a frozen finger.
Let's walk through the flexor tendon zones, focusing specifically on the notorious Zone 2. Why is an injury in Zone 2 so historically feared that it earned the moniker no man's land?
Zone 2 extends from the proximal edge of the A1 pulley in the distal palm to the insertion of the flexor digitorum superficialis, or FDS, on the middle phalanx. The anatomical complexity here is staggering.
Both the FDS tendon and the deeper flexor digitorum profundus, or FDP, tendon must glide seamlessly past one another within a remarkably tight, unyielding fibro-osseous synovial sheath.
When a laceration occurs in Zone 2, the ensuing inflammatory response almost inevitably leads to the formation of dense scar tissue adhesions between the two healing tendons and the surrounding sheath.
If these adhesions mature, they effectively weld the tendons to the bone, completely obliterating the gliding mechanism and resulting in a stiff, non-functional digit.
While modern multi-strand core suture techniques and aggressive early mobilization protocols have vastly improved our outcomes, Zone 2 repairs remain technically demanding.
Because the flexor anatomy is so intricate, our physical examination must be equally precise. If a patient presents with a volar laceration, you must be able to independently isolate and evaluate the integrity of the FTP and the FDS.
How do we execute this examination accurately? To test the FDP, which is solely responsible for flexing the distal interphalangeal joint, or DIP, you must physically immobilize the rest of the finger.
You hold the patient's proximal inner flange joint, the PIP, completely rigid in full extension.
Then you instruct the patient to actively flex only the very tip of their finger. If they can flex the DIP, the FDP is intact.
Testing the FDS is more complex because of the quadriga effect.
The FDS is responsible for flexing the PIP joint. To isolate it, you must completely neutralize the pull of the FDP.
You achieve this by forcefully holding all of the patient's uninjured fingers perfectly straight in full extension.
Because the FDP tendons share a calming muscle belly in the forearm, anchoring the uninjured fingers effectively paralyzes the FDP of the injured finger.
Once anchored, you ask the patient to flex the injured finger. If they can smoothly flex the PIP joint, the FDS is functional.
Let's discuss extensor tendon injuries and the exact orthotic splinting regimens required for their management. We will start with the distal injuries. Describe the anatomy and presentation of a mallet finger.
A mallet finger represents an injury to extensor zone 1, located directly over the DIP joint. The delicate terminal slip of the extensor tendon is either lacerated, ruptured, or avulsed from the dorsal base of the distal phalanx,
Often due to a sudden forced flexion of an extended fingertip.
The clinical presentation is classic, a loss of active DIP extension causing the fingertip to rest in a characteristic drooping posture.
The treatment is rarely surgical. It requires strict, unyielding, continuous extension splinting of the DIP joint for 6 to 8 weeks.
Compliance is paramount. If the patient removes the splint and allows the fingertip to flex even once, the delicate healing tissue is torn and the 6-week clock starts completely over.
Now, contrast the extensor mallet finger with its volar counterpart, the jersey finger.
A jersey finger is essentially the exact opposite mechanism. It is a traumatic avulsion of the FDP tendon from its insertion at the volar base of the distal phalanx.
It classically occurs when a tightly flexed finger is violently forced into extension, such as a rugby or football player desperately grabbing an opponent's jersey as they pull away.
The FDP tendon ruptures and often retracts proximally into the palm. The patient presents with an absolute inability to actively flex the DIP joint.
Unlike a mallet finger, a jersey finger almost always requires prompt surgical exploration and reinsertion of the tendon to the bone.
And moving proximally to the PIP joint, what causes the classic boutonniere deformity?
A boutonniere deformity is the result of an injury to the central slip of the extensor tendon in zone 3, located directly over the dorsal aspect of the PIP joint.
When the central slip ruptures, the extensor mechanism is compromised.
Over time, the lateral bands of the extensor tendon, which normally sit dorsal to the axis of rotation, gradually subluxate volarly, slipping below the axis of the PIP joint.
This completely alters the biomechanics. The lateral bands now act as flexors of the PIP joint, causing it to buckle into fixed flexion while simultaneously pulling the DIP joint into severe hyperextension.
We cannot cover the hand without detailing the catastrophic infections that can destroy its intricate anatomy.
You receive a consult for a rapidly swelling, painful hand. You are immediately evaluating for the presence of the 4 Canaveral signs.
We should indicate a pyogenic flexor tenosynovitis. This is a closed space infection racing up the synovial sheath. What are the 4 specific signs?
First, fusiform or uniform, sausage-like swelling along the entire length of the involved digit.
Second, the patient will instinctively hold the finger in a resting posture of slight rigid flexion to minimize tension on the inflamed sheath.
Third, and most exquisitely sensitive, the patient will experience severe agonizing pain along the volar surface upon any attempt at passive extension of the finger.
Fourth, there is profound tenderness to palpation directly over the anatomical course of the flexor tendon sheath.
If you identify these signs, the window for medical management is closed. The intense pressure within the sheath will quickly cause ischemic necrosis of the flexor tendons.
The mandate is immediate admission, broad-spectrum intravenous antibiotics, and urgent surgical exploration to incise and thoroughly irrigate the tendon sheath.
Another notoriously dangerous hand infection is the human bite wound, commonly referred to as the fight bite.
This typically presents as a seemingly innocuous small laceration over the dorsal metacarpophalangeal joint in extensor zone 5. It occurs when a clenched fist strikes an opponent's teeth.
Why is the biomechanics of this injury so uniquely dangerous?
The danger lies in the position of the hand during the injury. When the fist is clenched, the extensor tendon and the joint capsule are stretched tightly over the knuckle.
The tooth easily penetrates through these layers directly into the sterile MCP joint space,
Introducing a massive inoculation of virulent human oral flora, particularly Eikenella corrodens.
However, when the patient subsequently extends their fingers, the tissue layers slide proximally, effectively sealing the puncture wound and trapping the bacteria deep within the joint.
You must treat a fight bite as a severely contaminated limb-threatening wound. The protocol is aggressive surgical irrigation and debridement of the joint broad-spectrum antibiotics.
And crucially, you never close the wound primarily. You leave it open to heal by secondary intention or perform a delayed closure to prevent a catastrophic closed-space abscess.
Let's wrap up the upper extremity by clearly differentiating the two major peripheral nerve compression syndrome, carpal tunnel syndrome and cubital tunnel syndrome.
The physical exam findings are distinctly different.
Carpal tunnel syndrome involves the compression of the median nerve as it travels beneath the transverse carpal ligament at the wrist. Patients classically present with nocturnal pain and paresthesias, awakening them from sleep.
The numbness is specifically localized to the radial 3.5 digits, the thumb, index, middle, and the radial aspect of the ring finger.
In advanced neglected cases, you will observe profound weakness and visible atrophy of the thenar musculature at the base of the thumb.
Cubital tunnel syndrome, conversely, is the compression of the ulnar nerve as it passes through the cubital tunnel at the medial elbow.
The sensory symptoms, numbness and tingling, are isolated to the ulnar 1.5 digits, meaning the small finger and the ulnar half of the ring finger.
Because the ulnar nerve heavily innervates the intrinsic muscles of the hand, severe compression leads to profound grip weakness, atrophy of the interosseous muscles, and eventually a classic claw hand deformity.
That is an excellent breakdown. We are transitioning into Section 7, breast reconstruction and cosmetic principles.
When planning a breast reconstruction following a mastectomy, our algorithmic decisions are heavily influenced by the patient's oncologic treatment plan. We have to discuss the massive overriding impact of adjuvant radiation therapy.
How does radiation fundamentally alter the tissue environment, and how does it change our reconstructive approach?
Radiation therapy is designed to destroy cancer cells, but it inflicts profound collateral damage on the surrounding healthy tissue. It induces a progressive condition known as endarteritis obliterans.
The intense radiation damages the endothelial cells of the microvasculature, leading to vascular occlusion, chronic tissue hypoxia, hypocellularity, and severe progressive fibrosis.
The irradiated skin becomes tight, inelastic, and exceptionally hostile to foreign bodies.
If you attempt to reconstruct an irradiated breast solely with a silicone implant, you face a dramatically elevated risk of severe capsular contracture, wound dehiscence, and eventual extrusion of the implant through the compromised skin.
Because of this inhospitable environment, introducing completely new, healthy, non-irradiated, well-vascularized tissue via an autologous flap is universally considered the most durable and reliable reconstructive choice in this setting of radiation.
When we elect to perform an autologous reconstruction, the lower abdomen is our primary donor site. Let's compare the two dominant abdominal flaps, the Dieppe flap and the tram flap.
Both utilize the same lower abdominal skin and fat, but the surgical dissection and donor site morbidity are vastly different.
The tram flap, or transverse abdominis myocutaneous flap, is the historical workhorse. It relies on the superior epigastric blood supply.
To harvest the flap, you must sacrifice a significant portion, or the entirety, of the rectus abdominis muscle, essentially using the muscle as a carrier for the overlying skin and fat.
While technically faster and providing robust perfusion, sacrificing the core abdominal musculature results in significant donor site morbidity, prominently including a high risk of abdominal wall weakness, bulging, or frank hernias.
The DIEP flap, or deep inferior epigastric perforator flap, represents a massive evolutionary step. It utilizes the same abdominal skin paddle.
But the surgeon painstakingly dissects the tiny vascular perforators through the muscle fibers, completely preserving the integrity and function of the rectus abdominis muscle.
This technically demanding microsurgical dissection drastically minimizes the abdominal donor site morbidity while providing an excellent natural aesthetic outcome for the breast.
Let's shift to the complications associated with prosthetic breast reconstruction and augmentation. If a patient presents to your clinic suspecting their implant has ruptured, the clinical presentation is entirely dependent on the type of implant.
How do saline and silicone ruptures differ?
A saline implant rupture is an immediate, clinically obvious event. The outer silicone shell fails, and the internal saline solution rapidly leaks into the surrounding tissue pocket.
The body's lymphatic system absorbs the harmless saline within hours, and the patient literally wakes up with a completely deflated breast. It requires no advanced imaging to diagnose.
A silicone implant rupture, however, is frequently silent and insidious. Modern silicone gels are highly cohesive, often described as gummy bear implants.
When the outer shell ruptures, this thick, cohesive gel typically remains completely contained within the physiological scar capsule that the body has formed around the device. The breast volume and shape may not change at all.
Diagnosing a silent intracapsular silicone rupture generally requires dedicated imaging, specifically a high-resolution ultrasound or an MRI, to visualize the disrupted shell.
And we must discuss capsular contracture, the most common long-term complication of implant surgery. We mentioned it in the context of radiation, but it occurs frequently without it. What is the pathophysiological mechanism behind the breast becoming hard and distorted?
Whenever any foreign body is implanted into human tissue, the immune system responds by walling it off with a thin, flexible physiological envelope of scar tissue, the capsule.
In the majority of patients, this capsule remains soft and pliable. However, in capsular contracture, this fibrotic capsule becomes aggressively thickened and actively contracts, tightly squeezing the implant.
The current leading theory driving this severe inflammatory response is the presence of a low-grade subclinical bacterial biofilm on the surface of the implant, most frequently Staphylococcus epidermidis.
As the capsule tightens, it forces the implant into a rigid spherical shape, distorting the aesthetic appearance of the breast, elevating its position on the chest wall, and causing significant pain for the patient. Severe cases require surgical capsulectomy and implant exchange.
We also need to cover a very specific, highly testable malignancy directly associated with breast implants: breast implant-associated anaplastic large cell lymphoma, or BIA-ALCL.
This is not a cancer of the breast tissue itself. How does it present, and what is the required diagnostic workup?
BIA-ALCL is a rare, unique type of T-cell lymphoma that arises entirely within the scar capsule surrounding the implant. It is almost exclusively associated with the use of implants featuring a textured surface, which are designed to adhere to the tissue but create a chronic inflammatory environment.
The classic clinical presentation is a spontaneous, late-onset seroma, a sudden, massive fluid collection around the implant causing rapid breast enlargement, often occurring several years after the initial surgery.
The absolute required diagnostic workup involves percutaneously aspirating that peri-implant fluid under ultrasound guidance and sending it for specific cytology and flow cytometry, actively looking for the diagnostic CD30 positive T cells.
If BIA-ALCL is confirmed, the primary curative treatment is complete: en-bloc surgical explantation of the implant along with a total capsulectomy to remove the entire disease burden.
Let's transition into aesthetic principles, specifically focusing on the most terrifying, catastrophic complications we encounter in cosmetic practice.
You are in clinic injecting a hyaluronic acid dermal filler into the nasolabial folds or the glabella. Suddenly, the patient reports excruciating radiating pain.
The surrounding skin instantly blanches white or develops a mottled, violaceous, reticulated pattern. You have inadvertently caused vascular occlusion.
What is the mechanism, and what is the exact salvage protocol?
You have injected the thick, viscous filler gel directly into a facial artery, creating an instant mechanical blockade of the blood supply. This immediately threatens profound ischemic necrosis of the downstream facial skin.
Even more terrifying is the risk of retrograde embolization. If the injection pressure exceeds the systolic arterial pressure, the filler can be forced backward along the supratrochlear or supraorbital arteries.
Once the pressure is released, the arterial flow sweeps the filler directly into the central retinal artery, resulting in immediate, irreversible blindness.
The salvage protocol is an absolute emergency. You halt the injection instantly. You apply vigorous massage and warm compresses to the affected area to induce vasodilation.
You must immediately reconstitute and flood the ischemic area with massive doses of hyaluronidase, the specific enzyme that dissolves hyaluronic acid filler. You administer oral aspirin to mitigate secondary platelet aggregation and thrombosis.
And if the patient reports even a hint of visual disturbance, you initiate the emergency protocol and contact ophthalmology immediately.
Another aesthetic complication that commands absolute respect involves gluteal fat grafting, widely known as the Brazilian butt lift, or BBL.
We are talking about the risk of a fatal macroscopic fat embolism. How does this catastrophic event occur, and what is the surgical mandate to prevent it?
A macroscopic fat embolism during gluteal augmentation occurs when the cannula inadvertently penetrates deep into the highly vascularized gluteus maximus muscle.
The pressure of the injection forces large volumes of fat directly into the massive, thin-walled, deep gluteal veins.
This fat travels instantly through the inferior vena cava, directly into the right heart, and completely obstructs the pulmonary vasculature, causing immediate catastrophic cardiopulmonary collapse.
Because of the unacceptable mortality rate associated with this specific complication, the absolute non-negotiable mandate for gluteal fat grafting is that all fat must be injected strictly into the superficial subcutaneous tissue planes, remaining entirely superficial to the gluteal muscle fascia.
Deep intramuscular injection is universally condemned.
And finally, for the cosmetic section, a quick clarification on terminology. When utilizing injectable neuromodulators, such as botulinum toxin, to paralyze the frontalis or corrugator muscles, the toxin can inadvertently diffuse into the levator palpebrae superioris muscle,
Resulting in a severe, temporarily drooping eyelid. Make sure you are pronouncing this correctly when discussing it on rounds or in the clinic. It is pronounced ptosis, spelled with a silent P, P-T-O-S-I-S.
Okay, let's bring it all home with Section 8. Trunk, lower extremity, and genitourinary reconstruction. Lower extremity trauma reconstruction is heavily tested because it demands a comprehensive understanding of the reconstructive ladder and regional anatomy.
Let's set up a massive, high-energy, open tibia fracture with extensive soft tissue loss and exposed bone. We conceptually divide the lower leg into thirds to determine our flap options. How do we approach this?
The availability of local expendable tissue dictates our approach. If the massive defect is located in the proximal third of the lower leg, specifically around the knee joint in the upper tibia, the classic, highly reliable workhorse is a rotational pedicled muscle flap utilizing the medial or lateral head of the gastrocnemius muscle.
If the traumatic defect sits in the middle third of the tibia, the traditional reconstructive option involves mobilizing and rotating the soleus muscle flap to provide robust coverage over the exposed bone.
But the reconstructive paradigm completely changes when the defect is located in the distal third, down by the ankle and the distal tibia.
The distal third is notoriously unforgiving. There is virtually no expendable, redundant, local muscle or fascial tissue available to rotate into a defect.
Therefore, any significant soft tissue loss with exposed bone, tendon, or hardware in the distal third of the leg almost universally mandates the importation of vascularized tissue from a distant site via microvascular free flap.
And what are the specific workhorse free flaps we rely on for these massive lower extremity reconstructions?
The selection depends on the specific requirements of the defect. For versatile, pliable, thin fasciocutaneous coverage that drapes well over the ankle, we frequently utilize the anterolateral thigh flap, or ALT, based on the descending branch of the lateral circumflex femoral artery.
If the trauma has created a massive, deep cavitary defect that requires a substantial volume of well-vascularized tissue to obliterate the dead space and fight infection, we harvest the latissimus dorsi muscle free flap.
And if the high-energy trauma resulted in a significant segmental loss of the tibial bone itself, we require structural reconstruction.
For this, we utilize the fibula osteocutaneous free flap, which allows us to transfer a robust segment of vascularized fibular bone along with an overlying skin paddle to monitor the perfusion.
Let's shift from acute high-velocity trauma to the insidious challenge of chronic wounds. You are evaluating a patient with a chronic, non-healing ulcer on their lower extremity.
There is a fundamental unyielding framework you must systematically run through for every single patient to determine why the wound is stalled. What are the three critical pillars of this evaluation?
To heal any chronic ulcer, you must address three distinct variables. First, and most critically, you must objectively evaluate tissue perfusion.
A wound absolutely cannot heal without adequate arterial inflow delivering oxygen and nutrients. You must palpate pulses, obtain an ankle brachial index, or utilize advanced modalities like transcutaneous oximetry. If perfusion is inadequate, vascular surgical intervention is required before any reconstructive effort.
Second, you must actively assess for and eradicate any underlying clinical infection or heavy bacterial bioburden that is locking the wound in a state of chronic inflammation.
Third, you must ensure meticulous, uninterrupted offloading of the affected area. This is especially critical in diabetic foot ulcers, where profound peripheral neuropathy prevents the patient from feeling the sheer forces and repetitive trauma that are physically destroying the healing tissue.
And what if you were evaluating a chronic recalcitrant ulcer, perhaps over the heel or the malleolus, and you observe exposed, desiccated bone at the base of the wound, complicated by recurrent episodes of cellulitis?
What diagnosis must you aggressively pursue, and what is the definitive method to prove it?
When you see exposed bone in a chronic wound, you must inherently suspect underlying osteomyelitis, a deep-seated infection of the bony cortex and medulla.
While advanced imaging, such as an MRI, is highly sensitive and useful for delineating the anatomical extent of the infection, it is not the ultimate diagnostic tool.
The absolute gold standard for definitively diagnosing osteomyelitis and directing targeted antibiotic therapy is obtaining a surgical bone biopsy from the operative debridement and submitting it directly for deep tissue culture and histopathologic examination.
Finally, we must touch on genitourinary and perineal emergencies. Let's discuss the presentation and management of Fournier's gangrene.
This is a rapidly progressive, frequently fatal necrotizing soft tissue infection, an NSTI localized to the perineum, scrotum, and perianal regions.
The clinical presentation is unmistakable. The patient presents with severe, unremitting, agonizing pain that seems entirely out of proportion to the initially subtle erythema or skin changes.
This is rapidly accompanied by profound systemic toxicity, tachycardia, and impending septic shock. What is the surgical mandate when you recognize this presentation?
Fournier's gangrene tracks relentlessly along the continuous fascial planes of the perineum and abdomen, specifically Colles' fascia, Dartos fascia, and Scarpa's fascia.
Because the bacteria produce tissue-destroying exotoxins and cause widespread microvascular thrombosis, the overlying skin necrosis is merely the tip of the iceberg.
The infection is racing through the deep subcutaneous tissues. This is an absolute drop-everything surgical emergency.
The mandate is the immediate empirical administration of broad-spectrum intravenous antibiotics and rapid transport to the operating room for emergent, radically aggressive surgical debridement.
You do not delay intervention to obtain a CT scan if the clinical picture is obvious. You must incise the fascia and systematically excise all necrotic, non-viable tissue until you reach healthy, robustly bleeding margins, regardless of the resulting anatomical defect.
Source control is the only way to save the patient's life.
And lastly, regarding reconstructive efforts in the genitourinary region, specifically vaginal reconstruction for congenital agenesis or acquired oncologic defects.
We frequently utilize full-thickness skin grafts, local fasciocutaneous flaps, or even intestinal segments to recreate the vaginal canal.
Regardless of the surgical technique employed, what is the single most significant, frustrating, post-operative complication we must relentlessly fight against to ensure functional success?
The primary physiological challenge in any vaginal reconstruction is the overwhelming tendency for the newly created canal to undergo severe fibrotic contracture and stenosis as it heals. The body naturally attempts to close the newly created space.
Therefore, the surgical procedure itself is only the first step. Functional success is entirely dependent on the aggressive prevention of stenosis through the implementation of a strict, highly disciplined, and long-term postoperative dilation protocol.
If the patient is unable or unwilling to remain strictly compliant with a dilation regimen, the reconstructed canal will inevitably contract, and the reconstruction will ultimately fail.
We have covered an immense expanse of physiological principles, complex anatomy, and surgical algorithms.
Before we sign off, I want to leave you with the ultimate exam day tactic.
When you are sitting in that sterile testing center, staring at a convoluted, multi-layered, multiple-choice question, and two of the surgical options seem perfectly plausible and well-reasoned, what is the golden rule you must fall back on?
The golden rule of surgical decision-making, both on the boards and in the trauma bay, is unyielding. You always select the option that definitively protects life, vision, or limb first.
You never bypass physiological stabilization to jump to an elegant, definitive, complex reconstructive procedure.
If a patient has a mangled extremity and a compromised airway, you could cure the airway.
You relentlessly decompress the compartment syndrome, aggressively debride the necrotic tissue, and achieve absolute control of the infection before you even consider designing a free flap.
Life-saving physiological stabilization and source control always, unequivocally, precede definitive structural reconstruction.
Now, we have spent this entire deep dive meticulously breaking down the traditional reconstructive ladder. How we replace like with like, how we transfer skin, rotate muscle, and anastomose blood vessels to cover defects.
But I want you to consider the horizon. As we push the boundaries of composite tissue allotransplantation, achieving near-miraculous outcomes with full facial and bilateral hand transplants, and as we refine the incredibly precise science of targeted muscle reinnervation, the fundamental definition of our specialty is shifting.
The future of plastic surgery is no longer simply about finding tissue to cover a hole. We are entering an era focused on the seamless, functional integration of human biology with advanced neuroprosthetics and robotics.
As you master these traditional algorithms, ask yourself, will the reconstructive ladder of tomorrow bypass the skin graft entirely and begin instead with intricate nerve transfers, cortical integration, and robotic augmentation?
It is a fascinating, awe-inspiring frontier, and it is the future you are going to build.
That is exactly the mindset you need to cultivate. Take these complex patterns, memorize these non-negotiable numbers, and carry them directly into the clinical grind.
When you see a facial laceration in the emergency department, automatically test every single branch of the nerve.
When you admit a burn patient, physically calculate the fluid shifts.
Teach these concepts out loud to your junior residents, debate them with your attendings, or just talk yourself through the algorithms on your drive home until the knowledge is absolutely automatic.
That is the path to mastery. Keep pushing, and good luck.